Bismillahirrahmanirrahim. Assalamu alaikum and welcome to Diplomatic Enclave. I'm your host, Umar Khalid Bhatt. As is the topic of our show, we always talk about subjects that bring countries, citizens of different nationalities together to work on a single subject. And today we're going to talk about how medical education is important universally and how it is also very important for the different medical educationists to understand each other and to also try to impart a system of education that people from one country can follow in another country, because a lot of students from, for example, Pakistan go to other countries to pursue their higher education in medicine, and it's so very important to have that same ethical values and those same principles on which medical education is based in other countries, and it should also be based in countries such as Pakistan, so that when the students go abroad, they don't feel alienated, they feel part of the same system. Now, to talk about the whole system of medical education and how important it is universally and in the different countries from where my guests belong to, let me introduce my guests to you one by one. On my very right is Professor Olle Cate. Professor Olle Cate, you're from the Netherlands. You're an educational advisor at the medical facility at the University of Amsterdam. You've been there. Then you were a full professor at the medical education at the University Medical Center Utrecht. Then you were scientific director of the Medical Education Institute of the UMC Utrecht, chair of its management team. You've been the founder and director of the Center for Research and Development of Education at the UMC as well. You've been a professor of medicine at the University of California in San Francisco to date from 2012. You are also a professor of medicine, Unified Services, University of the Health Sciences in Bethesda from 2016, and an honorary professor at the Istituto Universitario del Hospital Italiano in Buenos Aires from 2017, and a scientific director for education at the University Medical Health Center Utrecht, and also a senior scientist at the Center of Research and Development at the Education at the UMC Utrecht since 2018. So it's a huge CV. Thank you very much, sir, to have joined us. Our second guest is Dr. Azim Mirzazadeh. Dr. Mirzazadeh is an associate professor of the Department of Medicine and the Department of Medical Education in the School of Medicine of the Tehran University of Medical Sciences. You received your diploma in health professions education from the University of Dundee in 2016. You've been involved in different aspects of medical education, including a major revision of the undergraduate medical program in your university in the last 15 years. You've worked in research and development projects at the both university and at the national levels, and you're currently the chair of the TUMS Department of Medical Education, and you are responsible for the training of the PhD and MSc students and the director of the Education Development Center of the Ministry of Health and Medical Education as well. Thank you very much, Dr. Mirzazadeh, as well, to have given us the time. It's a very interesting profile that I have today on my very show. Let's begin with you, Professor Olle Cate. Medical education, you've been through it, you've seen it in different countries now, you also see it in the United States, from Europe. How different have you thought, in your point of view, has been the system of educating medical students in Europe and in the US? What are the basic similarities and the differences that you've found?
There are essential differences, and within North America and Europe, essentially, and I think it's not very important, but it is a difference. That is, our structure of medical education in the Netherlands and in other countries in Europe is that students go to medical school right from high school. In North America, people do not go to medical school right from high school. They first have a college degree, usually an undergraduate degree, could be biology or any other topic related to medicine, before they enter medical school. And then medical school is 4 years, whereas in Europe it's usually 6 to 7 years, some 5 to 7 years, I would say. So that is a basic difference. Apart from that, there are some. So what is very important in the United States, there is a difference, is that there is a National Board of Medical Examiners that is very dominant for medical students, because they must pass the United States medical licensing examinations in different steps. Step 1 is after about 2 years, and then there's step 2 after at the end of medical school, and then there's step 3 in specialty. We, in the Netherlands, we do not have medical exams on a national level. We only have that in our own schools. So countries differ a little bit from that. But so the dominant component of that structure is different. So that is one difference. But we do think I think we are alike more than if you compare to some other countries.
All right. But which system do you feel, Dr. Cate, is more preferable as per your standards?
I think it's difficult to say. I naturally have a slight preference for the European system, but it also has drawbacks. So there's always a nuance to that. So the nice thing is that there's many years that you could have students under your guidance to have them become a medical doctor on different aspects of knowledge, skills, attitudes, professionalism. And we can shape them over a period of 6 years, whereas in North America it's much shorter. On the other side, you could say there's a benefit to a very wide background before you go to medical school. So sometimes it would be actually nice that if you've seen more of the world than only medicine when you start medical school.
How important is it, Dr. Mirzazadeh, to see more of the world before you start medical school, as Dr. Cate has said, to have an understanding or that basic also knowledge of whether you are passionate about it and you should or should not pursue it?
I think that we could not have a simple solution or answer to this question, but we have the same challenge and the same system as European countries, and our medical students just arrive and enter medical school after graduation from high school, and on the other side we have some licensing exam during the course of their education, and we found that students from high school usually don't have a good imagination and understanding about what is the medicine and what is the career in medicine. And therefore, if you have chance and you could provide opportunity for them to better understand the meaning of being a practitioner in the field of medicine, would be very helpful for them. But it's not so simple, because usually the family pressure on them, the prestige of health professions in the country could move them toward medicine. Therefore, I'm not sure that it is necessary to have, for example, a master's degree before entering medical school. But we need to provide more vision and more understanding of the nature of this career for our students before entering medicine, because medicine is not so simple job.
Exactly, it's a very tough curriculum to follow, and it's a whole lifestyle. It's a change in lifestyle, Dr. Mirzazadeh. I'm in conversation, ladies and gentlemen, with Professor Olle Cate and Dr. Azim Mirzazadeh, talking about medical education, the different aspects of it, and how different or similar are the different educational systems across the world, and how important it is for us also to understand and have a vision about it before we even begin to study medicine, so that we can become better medical educationists and better doctors as well. We'll be back right here after a short break. Stay tuned. Welcome back. You're watching Diplomatic Enclave, and I'm in conversation with Professor Olle Cate and Professor Azim Mirzazadeh about the importance of medical education and how important also is it to perceive the vision of those students who go through the medical education, to make them understand that this is a whole lifestyle that they are going to go forward with and pursue their whole lives, and so they need to understand that as well while they are studying it, so that they pursue it with their full passion. Now, Professor Olle Cate, you before the break we were talking about the prestige of the health professionals, the vision that they have when they enter the medical profession. In countries, for example, such as mine, Pakistan, and other countries of the region as well, maybe in Iran, I'm sure, there's a lot of sometimes family pressure to enter the medical field because the parents are doctors, because the environment is such that they say, oh, to become a doctor is something very prestigious, and it is, because they're looked upon very highly. So, and despite the fact that the student might not be very inclined to pursue medicine, but he or she then, despite the fact that he does not want to do it, goes through because of certain pressures from the society, from the family, or some other pressures. Do you as an educationist also see that in Europe? Does that happen in Europe? A, if it doesn't, if during the course of medical studies, have you ever seen a student kind of lack that passion or that vision to pursue the studies? And if so, do you push them to continue till the very end, or do you tell them or indicate to them that it's time to kind of search for something else or study some other field?
A very interesting question, I think. So let me start by saying that I believe that in the Western countries, at least in the Netherlands, the pressure of the family is less than in some other, maybe in your country and some other countries. So you have to realize that motivation is important for medicine. If people are not motivated, it will be difficult for them. They must find some drive to do all the things that they need to do in medical school. And the drive, hopefully, is mostly internal. So we've done many studies actually on motivation in medical school. And what you want is that people develop a sense of deep gratitude or satisfaction in the development of their competence, that is the development of their feeling of autonomy, that they're growing into a profession that they can take ownership of their own development, but also in patient care, and a feeling of relatedness. People need to be in a social structure. So those three things we know from the literature and from studies that we did are very important for intrinsic motivation. Now, some students go to medical school and pursue that just because of external motivation or extrinsic motivation, because of money, because of pressure from families, and they have to be really thoughtful about their drive to do this, because they might not end up as happy as they could. It might not be the right choice for them. It might distract them from the true spirit of what you want in a medical student. So I think even though those external forces will always in some way be present, it is nice to be a doctor, and it's nice to be highly valued in society. That's just fine, and there's nothing wrong with that. But if that's only dominant and there's no intrinsic motivation, people will have a difficult life, I think. Those people would be the people that you would have to talk with and maybe coach during medical school. Is this the right choice for you?
All right. Has we ever encountered something of that sort in your university or in your environment, Dr. Mirzazadeh?
Yes. The family pressure, as I told you before, is much higher in my country, and also the prestige and also the higher income. But I think that one of the major issues for medical students, most of them are so brilliant, and when they started their study as medicine, they are so enthusiastic to pursue their career. And I'm somewhat concerned about the impact of our educational system on their motivation. Some of them think about when we start medicine, there's a joyful and with relevance to what they think about medical practice. And usually during the first year of their study, they found nothing about it in the curriculum. And therefore, some sort of dissatisfaction comes from within the medical school, not before or outside of the medical school. And this put a great pressure on us as faculty members and also as administrators, how we could maintain their motivation to be a practitioner. I met a lot of students that talk about the impact of the system and the dysfunctional system, educational system, and their motivation. Usually we talk about how we could change the situation to have a better quality education, and also usually we talk about the different careers that they could have. For example, I have recently medical graduates that are interested in artificial intelligence, and after graduation they are entering and he is seeking to find a position to pursue. But usually we don't think about stopping, because it's so heavy for them and for the family to decide about this issue. Sometimes it's happened.
All right. When you talk of motivation, Professor Cate, there's also the selection criteria. I mean, sometimes you feel that A or B person is more apt to enter a certain field and not the medical field. Sometimes the person even does not know, but he's more apt for the medical field than for any other field. How do you select your students when they come for the examinations, of when they come to enter a university? Do you kind of also meet them, interview them, and kind of have that vibe whether they're really into it or up to it?
Mm-hmm. That's a very interesting question, because the Netherlands is a very particular country. I can tell you, and hardly anybody knows that 40 years long, since 1972 until recently, the entrance for medical school was determined by a lottery system. And we have to realize that many students actually come to medical school because they have had a very specialized secondary education, and only a minority of people are even eligible to go to medical school. Now, it is interesting, there was opposition against the lottery system, so now we do much more selection by interviews or by assignments or different ways in different schools. We are at this point not really satisfied whether that is a better system than a lottery system. It's interesting, so that may sound very strange, but you have to realize, and as actually Dr. Azim already said, the demotivation can actually happen during medical school. So it is even more important to think we have 6 years that we can educate youngsters. If they are at an age of 18, 19 years old, and they are at that moment really willing to go to medical school, and almost I would say 80 to 90% of all our medical schools who come to medical school are already motivated. And it's very difficult to make the difference between who is less motivated or more motivated. But I do think we can help sustain that during medical school. I think the period of medical school is much more important than the criteria of selection. Given the fact that people have already in the Netherlands went to secondary school with a package that makes them eligible for medical
All
school.
right. Dr. Mirzazadeh, that brings me to the whole concept of curriculum. That is the kind of education that one gets, whether one is in Pakistan, in the United Kingdom, in the Netherlands, in the United States, or in Iran.
Yes.
How similar or different, because you've been to different countries,
Yes.
how similar is the curriculum that we follow? I know the subjects, whether it be anatomy, physiology, biochemistry, surgery, medicine, ENT, they're more or less the same. But the way it is taught, how similar or different have you found that to be, and how much of an importance is given to, in your point of view, to the actual education, and how much of importance is given to the actual, how should I say, understanding or learning of the material that is in the books as per the different systems of education?
Let's talk first about the content. I'm not sure the content is similar. Maybe the title is similar, but the content I'm not sure, because the philosophy of many medical schools are somewhat different, especially in different countries, and the evolutionary nature of the curriculum. For example, you may have, for example, medicine as a content in different countries, but in some countries like me, many senior faculty members believe that the details of, for example, medical diseases the students should know, or even should be able to do something about it. But in some other countries, they believe that we train medical students to be a general practitioner or pursue their career.
But how much of training versus curriculum? I mean, this is also a huge debate that I've seen coming across. How much important is training versus curriculum while being educated for medical students?
We believe that curriculum has different aspects, and one of them is the content, one of them is the method, one of them is the strategy, and one of them is the assessment method. And all of these issues are integrated. We could not separate each part without considering other parts. For example, if you change your curriculum, but you didn't change your assessment system, students usually follow the assessment system, not the curriculum, not the content you provide, not the teaching method you provide. And therefore, about the content is similar, but the depths of the issue is somewhat different among the countries. About the methods, there are different methods, and I'm not sure that any specific methods are the best solution for all the countries, because, for example, as I know, the Western countries, the students are more student-centered. And if you use that method without any concern, without any preparation, the medical students in my country, or even maybe in Chinese students or in Pakistanis, they are not so keen to student-centered methods of teaching, because they believe that faculty members are top, and they should provide information.
Now, there's something very important.
The situation is changing.
Exactly. When I was going through your courses, you have been responsible for revising your undergraduate medical system of education. What did you revise? What was lacking that you thought needed to be revised?
When we started in 2005, we found there are some sort of unrest and unhappiness among faculty members and students about the curriculum. And we know that we have an old university medical school program for MD, and we are the best in our country, and therefore it's not a simple task to ask faculty members, please change your content, please change your teaching methods. And therefore we need a lot of projects to find the deficiencies, not only to find the deficiencies, to come to some sort of agreement among faculty members, among students, about the most important priorities of the curricular change. And therefore we found a lot of issues in different aspects of our curricula, about the content, about the outcome, about the teaching methods, about the strategy, usually teacher-centered, about the methods, mostly lecture-based, about the strategy, as I told you, about, for example, subject-based or integrated. about the assessment that is more summative, more knowledge-based, and not with appropriate feedback to medical students. Usually we lack evaluation of what we are doing, and therefore we couldn't provide feedback to our educational system. And therefore it's not a simple task, it's not a simple sort of revision that you could provide to have a better quality education for your students, and you should tackle many of them. And when you go through all these stuff, you may lose the deepness of your
and you revise it accordingly.
Yeah.
All right. Professor Olle, when it comes to the system of medical education in Europe, in the Netherlands, let's take the Netherlands, or in the United States, where you are also teaching currently, is the curriculum also revised on a regular basis as per the understanding of the faculty, as per the needs that are there in the medical profession or those of the students?
Yes, I think there is a general tendency to think that a curriculum should be revised every 10 years. Because there's so many things that are happening in society, or there's new educational insights. And I think, just to add to what Dr. Azim already said, is that I think the major curriculum reform started in the 1950s, and with the same disappointment that some students now have, go to medical school, lose our motivation. And why is that? And that because the curricula in the past have been created in ways that people would say it is important that you, as medical student, you have knowledge about anatomy, histology, sometimes physics even, or biology, and then like pathology. All those units were professors with their own departments. They would make their own small mini curriculum, and then the big curriculum was only a staple between all those plans. Now we think completely different about medical curriculum. We think we should look from objectives, from what actually define what a doctor is, and what should a doctor be able to do and know and have, and see if we can integrate that. So the Western schools now in Europe, in the Netherlands and United States, are much more integrated. So at our school, we don't have a course anatomy. We do not have that. But we have courses around organ systems, for instance. And we integrate even clinical topics with basic sciences to make sure that things are really relevant, that students can see the relevance. So that is a different approach. That was, sometimes we call that horizontal integration.
And that makes it even more interesting, doesn't it?
It is?
Exactly.
Excuse me?
It makes it more interesting. The whole concept of getting a medical education becomes more interesting because you're integrating so many different kinds of topics together in a way. You knit them together so as to make the whole topic more relevant, more up-to-date, more interesting. The student gets involved in it instead of just cramming the things out.
Exactly. So I can tell you that in the 1960s, all medical schools in the Netherlands had not hardly seen any patients before the fifth year of medical school. When the clerkship started, people had the idea, first the basic sciences. By then, the motivation for many people has gone lost because they have been working very hard, but the whole idea of caring for patients was on the background. Now we're not much more integrated in a vertical sense. So early patient contacts are important for both motivation, but also for understanding. If you teach the anatomy, why not teach that? So I've been thinking along with a New York medical school. The medical students start with a 3 months service in ambulance, in acute care. And they have a medical technician diploma before they even start with courses in the basic sciences. So because they start understanding what is a patient, what is a human body, what can go wrong, and why do we need to know this all? So that gives a different purpose to medical school. So integration is, I think, a key element of more modern medical schools.
And that is what is happening nowadays in the United States and in Europe as well. Professor Mirzazadeh, don't you feel there needs to be a uniform system of medical education around the world so that when an Iranian student or a Pakistani student goes to, for example, Netherlands or the United States to further his education, be a specialist or even get a medical degree from a certain country, that he or she does not feel alienated from the whole system because he's or she has been in a totally different system beforehand?
I'm not sure I'm true or not, I'm right or not, but I think that if you try to be so prescriptive in decreasing the diversity of medical education around the world, is not so good. At the same time, we need some sort of thinking about global standards and how we could approach those standards with consideration of our local context. Something like think globally and act locally. And the World Health Organization talk about it. For example, if you import a curriculum from Netherlands to Pakistan or to Iran, I'm not sure it's working well for faculty members.
But you can integrate the elements that you feel could be integrated in your
Yeah,
system.
we are working on integration. We have the same challenge for our medical students. They lost their motivation when they're just before arriving clerkship. And we started some sort of early clinical exposure. We have some sort of case-based discussions in the end of each organ system courses with clinical faculty and basic science faculty to show the medical students how they could use their basic knowledge to understand the medical problems, not to solve the medical problems at the stage, but this they should know about the relevance of what they are studying at the early phase of the medicine. But it's not so simple because the faculty members should believe in it. It's not so in many medical schools. The students should cope with it. We tried for the first time integration in our medical school, and at the first time medical students are not so keen to that because they think one of them told me that we are your guinea pig. To experiment some sort of issues, and therefore it's a very difficult task. But we need some standards that in the United States, in Netherlands, in Iran, in Pakistan, you should follow. And in this situation, the graduates, for example, from Pakistan or Iran, when go abroad, she or he has some sort of competencies, some sort of capabilities.
They can adapt themselves easily in that system as well.
But at the same time, there are, for example, in Iran, like Europe, I'm not sure like Europe, but after graduation, the medical doctor, after 7 years of studying medicine, they could practice as general practitioner. But in the United States, after graduation from medical doctor program, after 4 years, they don't have license to practice independently as a practitioner. And in the United States, you don't have any general practitioner. You have a generalist body, internal medicine, family medicine, pediatrician, but not general practice. Therefore, the system is very different in different countries.
All right.
But there are some main issues that very similar because it's about medical education development, it's about the human nature, and that's so different. The medical students in Iran, in Pakistan, in Netherlands, in the United States love to know why they should study basic sciences.
Even and how they should study them as well.
And this is the same. It's not so different. But implementation of this issue in different countries, in different cultures, should receive enough attention from all those involved in this. It's not a simple test. For example, if you change your curriculum from subject-based to integrated, even after that, the anatomists talk about only anatomy without any relationship with embryology, histology, physiology. Yeah. But it's a journey. It's a continuum of events. It's not just one point you are integrated, before that you are not integrated, after that.
It needs to be a constant progress, and it needs to be a constant system of development of the person as a medical student. And not only the development of the student as a person, but also as a professional, so that when he or she comes out of that institute, that he is a competent professional that can be in any environment, in any country of the world, and perform to a certain level.
And at the same time, you should change your assessment. Because if you change the curriculum, but you assess the details of anatomy independent from physiology, the students do not care the curriculum. The students care the assessment. Yeah, and you need the infrastructure and resources. For example, usually case-based discussion, usually not every time, occurs in small groups, and the resources that you need to do that is not a simple task. We could have some shortcuts, but you should think about the resources, the infrastructures on the human side and also on the logistics.
All right, that brings me to a very interesting perspective. How much do you agree or disagree with it, with what Dr. Mirzazadeh has talked about, the whole system of medical education and the assessment of the medical students, and the type of resources that need to be given to them, the lack thereof or excess thereof?
I think largely I do agree with this. So even though we can think of the best standards, we could look at the best country with the best school and say everybody in the world should actually do the same.
That's not possible.
That's not a route to go. So for one, the reason is that the healthcare demands in the countries are completely different. So in the Western countries, the medical degree has lost its significance.
Why?
That is because everybody with a medical degree must go to postgraduate training. There is no way to independently practice medicine. Whereas in many other countries, the majority of people are general practitioners, just do their work after their basic medical degree. So if we are really training people to give primary care, for instance, in rural areas, just with the medical degree, we have to train him to be able to do that. And that's training differently than for them to enter postgraduate training. But at the same time, I think some sort of integration of understanding why they need the basic sciences and how can. So maybe I can give an example from a Western country. So I have a student who is interested in anatomy and radiology. So we're planning to do a project to deeply think about how radiology should be involved in the training of the understanding of the human body. And just think of it, if in our current system with access to all sorts of information, most patients can get into their own medical records just from the internet at home. They will go to a general practitioner or to a family doctor and say, this is a picture of an x-ray that I have, or an MRI, or whatever. Can you explain me what this is? And the practitioner actually pulls up their own screen and goes into the same medical record, and will have to explain to the patient what they can see on all sorts of radiology images. So radiology in practice is so important for understanding the anatomy. So radiology and anatomy must work together to train students to be able to give that explanation to patients. So I think that sort of integration, and this is modern technology actually helps doing this, but it is so important to integrate it. And from the very start, why not educate medical students early on with radiology images, because that is their life in the future. It is not the open bodies if they're not going to become a surgeon.
Exactly, that's a very important concept or a different concept whatsoever to integrate students as per their needs or as per their interests, whether if they're, like you put on the case of radiology and anatomy and a student getting interested in both fields, and you said, oh, let's work on a project that involves the both of them so that the student gets even more interested in pursuing that field and then gets more passionate about it. But with passion, Dr. Mirzazadeh, with the studies, especially when it concerns medical studies, comes a lot of stress, comes a lot of issues, burnout as well, because there's a lot of things to understand, to learn, a lot of hours to put in, whether it be at the hospital being trained or learning different things, different subjects. How do you deal with students that are extremely stressed or who get stressed, come to you with issues of stress, of burnout? How do you console them or tell them to pursue them and get over this stress or this burnout? What are the different procedures to do that?
We encounter medical students, we encountered residents, and even we encountered faculty members who are who have some sort of burnout. And it's somehow it is the nature of medicine. Even without external pressure, when you visit a patient and you should manage a patient, even a senior faculty member usually have a lot of thinking and concerns and uncertainty about what is the problem and how I could and I should manage it. And therefore, sometimes it's the nature of medicine. The other side is how we cope with it. You could have different coping methods. For example, losing empathy is some sort of coping methods. You reduce the patient to a case, to a disease, and a subject to an object, and you don't have any feeling about an object, but about a person you should have some sort of feelings, and other people try to save their empathy and at the same time to cope with such a tough situation. On the other side is the role of faculty members. You blame your students, or you guide, or you help, or you assist the students. For example, some residents in ophthalmology told me that when one faculty members stand in the operating room, we are so easy and we are so happy because we know that he could help us and he would help us in any case of complex and difficulty during the surgery, yeah? And this is the part of faculty members, about how sometimes they come to us and talk about the bad experiences. You could blame him or her, you could ask him to think about it. What's their role, what's the nature of the disease, what's the system? It's not some sort of decreasing their role in that situation, but to think about it and how we could deal with it. And on the other side is the role of the system on the education and the system on healthcare.
All right.
And this is a puzzle. It's not, but at the same time, we should tell our students that despite all these difficulties, you should find something that help you to cope with this situation despite and with serving the patient.
All right. Professor Cate, how much do you agree or disagree with Professor Mirzazadeh as far as coping with burnouts or stress is concerned? And how differently or similarly do you deal with such issues?
So yes, I think it is a major concern now. One of the causes actually, I think, is that we have much more focus on patient safety. So patients must be treated safe and errors in medicine must be avoided. There is a big movement in the United States of patient safety, which actually leads to the fact that learners are not allowed to do much anymore. specifically in the United States, has gone pretty far in saying that all patients should eventually be treated by a specialist who has a specialist certificate. But if you think of it, if you are training residents in training and you will not let them do things by themselves, by the time they have their own diploma, they don't know what to do because they have never had that experience of full responsibility. So that makes it very, very stressful for them. So early practitioners are very much stressed because there is so much regulation. And in fact, if you think of it, it should serve patient safety and decrease of error if you have not learners take the full responsibility. But after it, the patient safety is jeopardized actually, because then they can have, with their diploma, start working in another hospital and have never experienced that full responsibility. So we have to find a better balance in doing that. And a balance that people are still in a safe environment, so they are in an educational environment, but get that full responsibility. I think we should do a better job in doing that. So that's one of the causes of that stress is a pressure on you. There's no possibility to make errors. And if we think of complications and errors, that's only a gray line between that. Sometimes you could say something went wrong and there was a complication that was unavoidable. But patients will start thinking, if it would have been the top specialist, it might have been avoided. Or so there is very much a pressure on that. So there's one thing. The other thing is finances. So in many countries, finances are so important that everything has to be registered, and the time that practitioners are allowed to deal with patients themselves is decreased. Like in outpatient clinics, there's only so many minutes per patient, and if you don't make that, there's some you'll get you're not making your full work job. So that pressure gives a situation that that people feel it is hard to do. There's many hours, but the hours alone is not the problem. I think there are hours in combination with an external pressure on both. You're not allowed to make mistakes, and you have to do everything really quickly and efficiently.
That is so true. Which brings me to the last questions that I'll address to the both of you, starting with you, Professor Cate. What are the elements in the structure of healthcare that you feel universally or regionally or continent-wise that we can work upon to improve the whole healthcare system from a medical educationist's point of view?
It's a pretty complex question. I don't think we can solve everything by education, but I think we can think more deeply about what can students, learners, residents, and practitioners actually do, and award them for that. Give them a license for units of professional practice. This is a major topic that I will be talking about in the education conference.
All right.
The coming days. And it is at a certain moment we need to include trust better in our education system, in our healthcare system. And we are now moving to systems of distrust much more. So have to control everything that happens. And we have to restore the idea of if we can start trusting learners for the things that we really know they can do, why not have them do that and give them that responsibility and the award for that? So it's a very general answer, but I think that it's an approach that touches both education and practice.
All right. What approach do you feel, Dr. Mirzazadeh, needs to be implemented by the different medical systems around the world, especially in the field of medical education, in order to improve the healthcare system?
We have the same problem. In my country, the not overemphasis on patient safety, more attention to patient safety may result in some imbalance between education of our resident students, on the other side the patient well-being and safety. The most important issue when I think in the education, because you know that the clinical education is inherently and should be in-service training, on-the-job learning. The medical student, the residents, the interns should have some sort of responsibility for his or her patient to learn. Yes?
Yes.
And if you provide some responsibility, there is a real danger of harming patient. And you should accept this, but you should provide better supervision, well-defined supervision. Usually in our system, we didn't have a well-defined supervision model, yes? And Professor Olle talked about the entrustable professional activities. At what level you could trust the medical student or resident could do that independently, and you should provide this situation. For nearly 20 years, during the last 2 decades, because I'm working in a division of general internal medicine in the largest hospital in the country, with many subspecialty services. We started this plan in our wards that we should provide responsibility and opportunity for interns to be involved and medical students to be involved in the process of patient management. Usually I talk about it with my students that you are the real care provider of this patient, and we are around you to help you to manage it, him or her well. And this is a major issue, and this healthcare system should trust the education, and on the other side, the education side should provide enough supervision to encourage and to being acceptable for healthcare system to provide opportunity for students to have some responsibility and to deal with patients.
That's very interesting. That's very interesting. And on that note, I'll end this very interesting educational episode of Diplomatic Enclave. I've learned a lot about the whole process of the educational system, and this puzzle, as Dr. Mirzazadeh said, needs to be put together very delicately between the educational system and the system of teaching and the system of actual learning and the system of implementing that learning in the society, whether it be in the West or in the East. And it's very important for countries around the world to understand that, to integrate that in order to become better professionals, so that if you are good professionals, then you impart that to the society, and the society becomes a better place to live in, a more healthy place to live in. Professor Olle Cate, Professor Azim Mirzazadeh, thank you very much for your input, for your insight into the medical educational processes in your different countries and continents, and how it is important to also evolve with the times and also make the students understand the importance of it for themselves and for the patients that they are treating. Ladies and gentlemen, that brings us to the end of this very interesting episode of Diplomatic Enclave. We'll be back inshallah next week, same time, same channel. Take care of self.